Then why did you put it?
So when we talk about supraventricular tachycardias, we actually refer to either long RP or short RP tachycardias. And these are the good differentials of a long RP tachycardias. I'm sure we've gone through all this before in our discussions as a group. So long RP tachycardias, these are the possible differentials of a long RP tachycardia. Then for short RP tachycardias, these are the possible differentials of short RP tachycardias. Now, we all know that what differentiates long RP tachycardia from short RP tachycardia is the duration. So when we talk about the durations of apologies for the interruption. So as I said, when we are doing talking about short RP tachycardias, the most important differential to you for short RP tachycardia is the AV nodal reentrant tachycardia. So for AV nodal reentrant tachycardia, which mechanism we avoid, we know before. Everything is happening around the AV node. So anytime you are doing an EP study and it's a short RP interval, the most important differential you want to really be sure of or rule out is AV nodal reentrant tachycardia. Another one that can be would be the autodromic AV reentrant tachycardia. So in that situation, we should note that the autodromic AV reentrant tachycardia means that it's using the conducting fibers to conduct from the atrium to the ventricle. So, and that is why they will have a short RP interval. Now, so what makes something a long RP? If we have questions, please just kindly ask. So what differentiates a long RP from a short RP is the timing. It's the timing. So if it is less than 70 milliseconds, that means between the R and the P. If it's less than 70 milliseconds, you will say it's a short RP interval. If it is more than 70 milliseconds, you will say it's a long RP interval. Now, so the classical diagnosis for a short RP interval is a typical AVNRT. Typical AVNRT simply means that it's using the isthmus as the area that is generating the tachycardia. Atypical AVNRT will present with a long RP interval, and that is about the kind of fiber they use. I'm sure in subsequent discussion, when we start talking about the mechanism of the arrhythmias for this condition, you will know why there is atypical and atypical AVNRT. Now, a typical AVNRT will use the fast-slow pathway. So simply means that if it's going to conduct fibers retrogradely, it is going to use the fast pathway. If it's going to conduct electrical activities antigradely, it's going to use the slow pathway. So in that condition, the P wave will be almost embedded in the QRS complex. So that is the typical form of AVNRT. And that's why they will have a short RP interval. But in the atypical form, the patient can have a slow pathway, in the sense that there is a slow conduction retrogradely and slow conduction antigradely. So the RP interval will be longer because of the slow retrograde conduction back through to the atrium. So that is why an atypical AVNRT will give you a long RP interval. Okay, so the next, I'm sure we already understand the mechanism of how we generate the AVNRT, but it's based on the impulse of a premature complex. So in those patients, they have two fibers, two pathways, the fast and the slow pathway. Some will have slow pathway, two slow pathways, and some would also have fast pathway. However, the most common is the slow fast pathway, in which an premature electrical impulse enters into the circuit. So the moment the premature impulse enters through the circuit, usually that is what will generate the reentrant tachycardia. It would enter into the relative conductive period of the fast pathway. And so, moment you enter into that, so that means the retrograde conduction will be through the fast pathway, and the antigrade conduction will be through the slow pathway. And so that is what gives you the typical form of AVNRT. Purpose of our discussion basically is to make a diagnosis with our EP in the EP lab. Just a brief talk also on the AVRT, which is the Wolff-Parkinson White. We also have discussed previously the orthodromic conduction and the antidromic conduction. So orthodromic conduction, which we all know, means that it's using the native conducting fibers to conduct from the atrium to the ventricle. So it's using the AV node, the bundle of E's, and its fibers to conduct through the ventricles. So that means that the QRS duration you're going to generate will be a narrow complex QRS. So that is why they call it a concealed pathway, because the QRS is narrow. So you're not going to see all the delta waves and things like that. But if it would use the accessory pathway to conduct retrogradely to the atrium. In the antidromic, that means that it uses the accessory pathway to conduct to the ventricle. Now, the ventricular cells are slow conducting fibers, slow conducting myocytes. So before they would get the electrical impulse to connect to the bundle branches, that will take time. So that means your QRS duration will be broader. You have a longer QRS duration. And so it uses the bundle branches, the E's, and the AV node as a retrograde conductor back to the atrium. And so, because you're going to conduct through the accessory pathway to the myocyte, that would give us the abnormal activation of the ventricle, which generates the delta waves, which is the pre-excitation we have in AVRT, as compared to the concealed type that uses the normal conducting fibers to depolarize the ventricle which subsequently gives you a narrow QRS complex. Please, if there's anything you are not getting, let me know so that we can re-explain. I'm just going through all this because I know we've discussed it previously. So I just want you to just brush through them. So accessory pathways can be located anywhere in the atrioventricular junction, either in the RV free wall, close to the tricuspid valve, anywhere, or close to the ease itself, the AV node and ease, which we call paraECIan pathway. It can also be along any part of the septum, anterior, posterior septum. It can be anywhere around the AV node, around the mitral valve, and it can also be in the lateral wall of the ventricle. So it can be at any location. All are all forms of AV reentrant tachycardia. So your duty in the EP lab is to locate the location of the accessory pathway and try to ablate that accessory pathway, which becomes a curative treatment for the patient. Another important basic term we should know is when we use the word A, H, and V. So A represents the atrium, atrial electrical impulses. H represents the impulse at the east, and the V represents the impulse in the ventricle. So anytime you hear us using the word AH interval, so that means between duration of electrical impulse between the atrium and the east. That is the AH interval, and that tells us the property of the AV node. When you hear the word HV interval, we're talking about the impulse from the east bundle to the ventricles. Okay. Remember we said the P wave we talk about is summation of both atrial depolarization, while the QRS talks about the summation of both ventricular depolarization. Another important thing we should note is action potential when we're talking about EP. We should actually understand action potentials and how it influences your EP studies. We all can remember everything we talk about from the different phases of action potential. These are things we know. The phase 4, phase 0 to phase 3. Now, there's something important why we should note this action potential. Is talking about the effective apologies. ERP, effective refractory period, the relative refractory period, and the functional refractory period. We'll still get to that. Since we already understand the physiology of the action potential, it's important to note the effective refractory period, which is the period at which we know that myocyte will not respond to any stimulus. Relative refractory period, the period at which you can still stimulate that myocyte so that to generate another action potential. And the functional refractory period, which I'll also further explain, is the time duration between the effective refractory period and the relative refractory period. Now, I just brought up this picture just to tell us that action potential is very important when we are doing EP studies. The action potential for myocyte is different for the action potential for the SA node and AV node, which we also know very well. The kind of current gates for the SA node and AV node, which is clearly stated on this slide, is different from that for the myocytes, which is more of sodium, calcium, and potassium channel. That for the AV node essay note is more of the funny comments, which we have all studied before. Okay, as I said, if you have any questions, anything to recap or further expatiate, let me know. This is just supposed to be a brief discussion of the introduction. Now, so I previously discussed about effective refractory period. Why does it relate to our action potential? And why is it important in the EP study? From our phase, previously we know that this ascending limb is phase 0. We have the phase 1, which is the short, which is the opening, rapid opening of the potassium channel for a short duration. And the phase 2, which is the calcium channel here. And the phase 3, which is now the opening of the full opening of the potassium channel. So effective refractory period simply tells us the period at which you cannot depolarize the myocyte, no matter the voltage you apply for that myocyte. Now, relative refractory period is in along the phase 3, the later part of phase 3 to phase 4. These are periods where you can still re-stimulate that myocyte even before the full recovery of the myocyte. So at that time, we can generate another action potential. But just important to note that the action potential you're going to generate at that time is going to be a slow velocity, slow conducting action potential. It will be slower than compared to when that myocyte has fully recovered. Now, there's one terminology we should now know. It's called the functional refractory period. So the functional refractory period is the shortest time at which you can re-depolarize that myocyte. The shortest time interval. So let's look at this picture, for instance. In this picture, you can see that the effective refractory period is from this phase 0 to the early part of phase 3. You cannot depolarize the myocyte. But after that period, the later part of phase 3 to phase 4 is the relative refractory period, which you can actually re-stimulate that myocyte. So it simply tells you that if you re-stimulate this myocyte at phase 4, before phase 4 is completed, you are still in the relative refractory period. If you stimulate it at the later part of phase 3, it can still get stimulated. That is relative refractory period. If you stimulate it at this limb area, well, you can still stimulate it. It's still the relative refractory period. But if you now stimulate it far much earlier, it will not respond. So the time interval, the shortest time interval between the most earliest time you can stimulate this myocyte before its effective refractory period is called the functional refractory period. So just following my arrow, the time interval between the end of effective refractory period and the earliest time of relative refractory period is the functional refractory period where you can stimulate the myocyte. Hope that is clear. Dr. Gordon, I hope I'm not over discussing or over talking.
Professor.
It's clear, right? Any questions so far? Any questions from anyone so far?
Good evening, sir.
Yes, madam. Ask me. Good evening.
The AVNRT,
Okay.
where something blocks the fast pathway, and I still don't understand that bit very well.
Okay.
Yes.
This segment,
Yes,
right? AVNRT.
Yes, sir.
Okay, so let me further explain this. Okay, although in subsequent sessions when we'll still further buttress it, but it's best to understand it first, so that further discussion will just emphasize the same thing we've already know. So it's said that for most people, there we have two pathways in the AV node, a fast pathway and a slow pathway. They are just two cables, fast cable and slow cables. For example, we all know our different phone chargers. Either you're using iPhone, you're using Android. We all know some chargers can charge your phone very fast, depending on the voltage of that charger. Some chargers are 20 watts, some are 60 watts. The latest one we heard now that Elon Musk has made for his phone company is 100 watts. And it says that it can charge your phone within 30 minutes, compared to some that will have to charge your phone for 2 hours. Okay? Now, so that means the cables have different conduction velocity, right? So that means we have slow chargers and fast chargers, slow fibers and fast fibers. So on a normal day, when impulse comes from the atrium, it will pass through the cables, both the slow and the fast. But because the fast will be the one to conduct faster than the slow to the ventricle, then by the time the slow conduction is coming, it will get blocked because the fast has conducted and the tissue is in the effective refractory period. So thank God we've actually discussed effective refractory period and relative refractory period. So it means that when conduction passes through the fast pathway, it will quickly depolarize that ventricle or depolarize the East bundle that is going to pass through. Meanwhile, by the time slow fiber is getting there, it's not going to get conducted because it is in its effective refractory period. You get that now? However, this will continue until there'll be a time that a premature conduction, APCs can happen for whatever reason, a premature atrial conduction would happen that even though the normal conduction has passed through and the slow pathway is blocked because it is slower than the fast pathway, when a premature conduction happens, it can easily get entrance into the slow pathway because there are two properties of the slow pathway. It slowly conducts, but it is fast at recovery. So that means it has a shorter period, or I'll use the word, shorter functional refractive period. So it means that it slowly depolarize, but it recovers very fast. And so that means that because it recovers very fast, when the first normal impulse passes through, it is slow to conduct it. But because it gets blocked, it recovers very fast. So if a premature conduction happens, it's very easy that it's going to pass through it because it recovers very fast. Unlike the fast pathway conducts very fast, but recovers very slowly. Okay? So that means that if a premature impulse comes, it will not pass through the fast pathway. Why? Because it is slow to recover. It has not recovered from the fast conduction, from the first normal impulse that passed through it, from the first fast conduction. While the slow pathway has recovered. So a premature impulse can easily enter into it. Hope you get that, man.
Yes, I think so.
Now, so that means if a premature impulse gets into the circuit of the slow pathway, by the time it is getting to the ventricle is already in its relative refractory period, even though it has not fully recovered. it is in its relative refractory period. At that time, it can get stimulated. And as at that time, the fast pathway is also in its relative recovery period, right? And so it can conduct retrogradely. So in its conducting retrogradely, it can pass the impulse into the atrium retrogradely. And remember that the slow pathway, we said, has a very fast recovery. It can easily receive back the retrograde conduction back again into its antegrade limb. And the fast pathway now is now in its effective reparatory period. It takes back the circuit back up retrogradely. And so that is where you generate the circuit or the circus of reentrant tachycardia in the AV node. I'm not sure if that is clear, man.
It's clear, sir.
So it's based on the conducting property of both fibers. The slow pathway ab initio has slow conduction but fast recovery. So a normal impulse, when it enters it, it will slowly conduct, but it will get blocked because the fast pathway has conduct faster and it has turned the tissue to effective refractory period. But it has faster recovery than the fast pathway. So that means that a premature impulse which wants to enter a fast pathway which has a slow recovery will be blocked. But it will enter a slow pathway because the slow pathway has a fast recovery. So it will just carry that nidus of premature impulse. And by the time it's getting to the ventricle is now in its relative refractory period. So it can easily get stimulated. And that would enter into the relative refractory period of the fast pathway. And the fast pathway has no choice but to conduct the impulse retrogradely. Remember, they are cables. So they can conduct antegradely, they can conduct retrogradely. Okay? So that is how the circuit gets generated. And the slow path. Is that what?
I said thank you, sir. It's clear.
Okay, so it's clear, right? Okay, good. All right. So we've explained that of autodromic and antidromic pathway for AVRT. So if you have any questions, you can always ask at any time. Okay, so we've tried to expatiate on what we mean by effective refractory period and relative refractory period and functional refractory period. So functional refractory period is just the shortest time interval between effective and relative refractory period. Okay. When we do these EP protocols, we usually want to do remember we're using to make diagnosis, right? And the treatment is with ablation. So in making a diagnosis, we need to generate or initiate or test the tissue property. So first we want to test the tissue property and also to induce arrhythmia. So we test the different fibers property. So we can test the property of the SA node to be a pacemaker and how it conducts. We also test the conducting activity of the AV node and how much refractory period or refractoriness it has. We all know that the AV node can block multiple impulses, excess impulses coming from the atrium. So you want to test it has a high refractory nature. So also we are testing the conduction across the bundles, its bundle branches, and their refractoriness. Also, we want to test for inducing arrhythmias in the atrium. Then for the ventricular protocol, what we are basically testing is to induce arrhythmia in them and also their retrograde conducting property. We know, as we said, there can be retrograde conduction from the ventricle to the atrium, which we call the VA conduction. Also, we test different drug properties along the tissues. So the antiarrhythmic agent properties can also be tested during EP study. For example, we can test the tissue response to sympathomimetic agents like isoprenaline, dobutamine. We can also test the property of the SA node, AV node to these medications. So those are things that can be done in the EP studies. So during EP, there are some important terminologies we use, which I previously described one. During EP, we have our surface ECG on the patient. You can use 12 lead, 3 leads. So basically, they usually use 3 leads, V1, lead 2, lead 3. We remember we said catheters are placed in different parts of the chamber, and it's only talking that it's only going to be testing that particular chamber. So if you have a catheter in the eye right atrium, so it's labeled HA. An important thing we should note is that this catheter, the particular catheter we are testing, we said they have you can use different poles for the catheter. You have bipolar, decapolar, octapolar, depending on number of poles you have. You can actually fragment those poles into proximal, mid, and distal. So for example, now we can have eye right atrium, and I can fragment the number of poles to proximal part of reading on the computer. Hope I'm still audible. I hope my network has not disappeared. Am I still audible?
Yes, sir.
Yes, sir. But at the point, I think we lost.
It disappeared at the time, sir.
Oh, apologies. So please, where did you hear me up to? Let me know where you heard me up.
When you were talking about the fragmentation of the RA.
Okay. Okay, great. So I was trying to say that we can have a catheter in a chamber, and we can fragment the reading. So just the same way you can have 3-lead ECG, you can have 6-lead ECG, right? You can also have 12-lead ECG, right? So the same way we can do for the catheters in the EGM. So for example, for the eye right atrium now, we can fragment it into 3: distal, mid, and proximal. The same we can do for the east bundle. So you can have the proximal east, mid east, and distal east. And you can have the proximal CS, mid CS, distal CS, or you can have CS based on we said CS catheter usually 10 catheters. So based on the 10 poles, you can have CS 1 and 2, CS 2 and 3 and 4, 5 and 6, 7 and 8, 9 and 10, just like that. So you can fragment it depending on the number of waves you want. So that when we are reading the EGM reading, you'll be able to understand what they mean by the number of waves you are seeing. You'll not get confused with it. Now, so going back to this basic EGM, so we have our surface ECG here. You will determine the number of surface ECG you want. We have the eye right atrium. That means this reading is monitoring the activity in the right atrium. As I said, you can have it as proximal, mid, and distal, different readings. Eye right atrium, remember we said can only monitor activities in that atrium. So it can only be recording atrial activity, right atrial activity, not even left atrial activity. And that will correspond to your surface ECG of P wave, right? And you can see it's the earliest part of the P wave. Now, the east catheter, we also said, can be divided into proximal, mid, and distal, or you can make it as a single reading. So you can, the east, remember we said, is as a proximal head sliding into the right atrium. A portion is touching the east, and the distal end is sliding into the right ventricle. So just the same way, I'll go back to this east catheter again. You can see the proximal end is in the right atrium, is a portion that is touching the east, and there's a distal end that is also sniffing around the ventricle, the right ventricle. And for the CS, you have the proximal end in the right atrium, a mid portion in the sensing the left atrium, and a distal portion sensing the left ventricle. So that's the way it's going to be represented on the EGM. So we've said, as I said, the east has a portion that's in the atrium, a portion is touching the east, so which we call the east spike, and a portion is touching the right ventricle. For the CS, we said a portion is touching the atrium and a portion is touching the ventricle. Now, remember we said the CS, you can break it down. They are usually, depending on the number of pole catheters you use, the decapolar catheter, you can have the different reading for each poles for the 10 poles. Okay? So it will show you the different portion depending on the pole you are referring to. So for example, the proximal pole that is in the right atrium, usually labeled, so the poles, so let me first say that the catheter is labeled from the distal to the proximal. So distal is 1, 2, 3, 4. You keep labeling that catheter to the proximal end. So let me go back to this. Apologies that I'm going forward and backward based on the catheter. So this is like a CS catheter now. So this portion is the most distal part is labeled 1, 2. We have 3, 4, 5, 6, 7, 8, 9, 10. So that means your 9, 10 will be more close to the right atrium. Your 5, 6 will be more close to the left atrium, while your 1, 2 will be more closer to the lateral wall of the atrium and the left ventricle. So that when we are looking at the EGM, anytime you are seeing 9, 10, that means it's closer to the right atrium. Anytime you are seeing 1, 2, it's far closer, it's at the far lateral wall of the left atrium and ventricle. I hope it's clear. Okay. You can now understand why the CS catheter can both capture the atrium and the ventricle. Now, we said the RV catheter is only in the right ventricle. You can also break it into proximal, mid, and distal, but since it's only sitting in the right ventricle, it's only going to be capturing the ventricle. So it's not going to capture anything more than that. If you also have the catheter in the left ventricle, that's the only thing it's going to capture, the left ventricle, not the right ventricle. There are some periods and intervals we should be aware of. The same way we have intervals on ECG where we talk about PR interval, QRS duration, and things like that. We also have intervals when we are doing EGMs. So for example, remember we said that the right atrium catheter will only monitor the right atrium. The east catheter is sliding around the right atrium to the right ventricle. So the interval between conduction from the upper end of the SA node to the lower end of the right atrium, which will be sensed by the east catheter, is called the interatrial conduction time or sinoatrial conduction time. Okay? The time interval between conduction from the atrium, lower end of the atrium, to the bundle, to the east bundle, which represent the property of the AV node, is the AH interval. So your AH interval is actually the AV node, just like the picture we described earlier. So your AH is actually the AV node. Now, from the east bundle to the time the conduction gets to the ventricle is actually the HV interval. So why this interval important to you? So that when you are making diagnosis of bradyarrhythmia, it's either for AV block now. For AV block, we all know the time when we use the word nodal block and infranodal block. So nodal block will be detected by the AH interval. So that means that if the AH interval is prolonged, you know there is an AV node problem. It's a nodal problem. When the HV interval is prolonged, we know that it's below the AV node. It's infranodal. So that is a bundle. So that's the bundle problem, infranodal. Okay? Any questions so far? The next cycle interval we
Sorry,
usually...
bro.
Okay, sir.
The CS catheter, does it also touch the LA or just the LV?
No, I said, so look at this again. Let's go back to this picture. So you can see the CS catheter here. It passed through the coronary sinus, right?
Yes, sir.
So you can see this chamber is what? The left atrium.
LA, yeah.
This chamber is the left ventricle. So this CS catheter can be so long sitting the CS from here to here. So let me use this image to look at it. So this is a CS catheter, these broken lines. Can you see?
Yes, sir.
So you can see that it's sitting between, and the CS is in the atrioventricular groove posteriorly. And we said that the posterior chamber is the left atrium and the left ventricle. So you can see the way it is sitting between the left atrium and the left ventricle. So you can
Yes,
see
sir.
why it's going to record both atrial activity and ventricular, left ventricular activity. And at
Thank
its
you, sir.
proximal end, where it enters into the CS, that portion will be sensing what? Right atrial, lower right atrial activity. So that's why we said CS9 and 10 will be the earliest to depolarize because it's closer to the right atrium, while the CS1 and 2 will be the last portion to depolarize because it's farther away from the SA node. Hope that is clear, sir.
Yes, sir. Very clear. Thank you very much, bro.
Okay, sir. Thank you, sir.
Yes, sir. Prof, sir.
Yes, sir.
Prof, sir.
I'm hearing, sir.
Yes, sir. Sir. Thank you, sir. So the CS catheter is decapolar. Understand that.
Yes.
Then for his high right atrium, left ventricle, and his catheter, is there any name? If I can see, like for the his, now I can see that it has, I can see 1, 2, 3, 4. Is there any name for them?
So as I said, based on naming, they are both positive and negative electrodes, right?
Sir.
Good. So 2, so that will be bipolar, right? If it is 4, tetra, right? If it's 8,
tetrapolar, yeah.
octa. If it is 10, deca, right? So it's just the same terminology we use, common terminology we use.
All right, sir. Thank you, sir.
Okay, so we'll soon be rounding up. I just want us to just quickly see some things here. We've understood well these conduction intervals. The next is to also understand the basic cycle length on EGM. We all know that your P will be best monitored by the RA catheter, right? So between the first A and the next A is the basic cycle length. So that is like determining the heart rate of that patient. So if you want to determine the heart rate for this patient now, all I need to know is the time interval between this and this. Then I divide it by 60,000. Hope you understand how we use 60,000. So for example, if the time interval between year and year is 1,500 milliseconds, I will divide it by 60,000. Then I will get the heart rate. And maybe the heart rate will be like 40 beats per minute. So, Dr. Gordon, do you know why we use the word 60,000 as this cycle length?
No, please.
Okay, so it is very, 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 very easy. So remember that heart rate is what? Determined in minutes, right? You say the patient has 40 beats per minute, right? 60
Yeah.
beats per minute, 70 beats per minute, right?
Yeah.
So how many seconds make a minute?
60 seconds.
Good, fantastic. So how many milliseconds make a second?
1,000.
Good. So how many milliseconds makes 60 seconds?
60,000.
So you now understand why we use 60,000.
Yes, please.
Okay, good.
Thank
So
you.
if we tell you that the cycle length from this to this PP interval is 1,500 milliseconds, you should understand why you have to make your division with 60,000. Okay? All right. So we already understand our basic cycle length. So basic cycle length, you are trying to determine the heart rate, just the same way we talk about PP interval, you get. So to get the heart rate or SA nodal rate. Now, we all know that cycle length varies, right? And so it's always good we correct for cycle length. Now, one important aspect is that we use that cycle length to determine SA nodal function. How is the SA node functioning? Does the SA node have a problem or not? Okay, and so just having a cycle length of this range to this range might not be sufficient. You might need to correct for cycle length. We all know that sometimes people can have sinus arrhythmia. In inspiration, heart rate is this, at expiration, heart rate is another rate. So we need to correct for all those variations, okay? So that is why we have some other terminologies that have been introduced. So there's what is called sinus node recovery time. What does sinus node recovery time mean? So sinus node recovery time helps you to know the ability of the SA node to recover after suppression. After suppression. So we can suppress SA nodal activity by doing what? Pacing around the atrium to suppress the intrinsic SA node. So for example, a patient's SA node rate can run between 60 to 100 rates, right? So if we start pacing the atrium at 150 beats per minute, you will know that the SA node will not run faster than that. Okay, so that means you can suppress the SA node. You can as well pace it at 200 beats per minute. You would suppress the SA node. Now, after you stop pacing the atrium, you would expect that the SA node should recover back its pacemaker function, right? So, the time interval between the last time you paced that atrium to the next normal sinus SA node recovery, that time interval is called SA nodal recovery time. So let's show us in this image. So let's use this image for instance. So this is a normal SA node activity for this patient. You can see the P wave, you can see the QRS and T. But they started pacing this patient at 400 milliseconds. So 400 milliseconds, that means 60,000 divided by 400 milliseconds. Let's just hypothetically say maybe it is 200 beats per minute. So hypothetically, let's say they are pacing at 200 beats per minute. And they kept pacing, and at a time they stopped pacing. So they now waited for the normal SA node function of this patient to recover back. So the time interval between the last time they paced to the time the SA node recovered, that period is called the sinus node recovery time. Hope that is clear. Okay.
Yes.
I think it's also an MCQ question in Brownwood. Now, if you remember that before you start pacing, this patient already has his own basic cycle length. That means between his PP interval, or the interval between the AHA wave, the basic cycle length. When you started pacing, we suppressed the SA node, and the SA node now recovered after we stopped pacing. So we were able to get the sinus node recovery time. If we subtract the basic cycle length from the sinus node recovery time, then we are going to get the corrected sinus node recovery time. And that corrected sinus node recovery time should be less than 500 milliseconds. So if it's less than 500 milliseconds, we will say that, okay, there is normal function of the SA node. If it's far higher than this, you will say that, oh, there's a dysfunction of the SA node because it did not recover as early as expected. So that's one of the ways you will make a diagnosis of SA node dysfunction. Hope this is clear. I just want us to know that there is basic cycle length, there is sinus node recovery time after you stop pacing, and there is the corrected sinus node recovery time by subtracting the basic cycle length from the sinus node recovery time. So these parameters help us determine the SA node function. Remember, we said one function of the EP study is to define this abnormality of the bradyarrhythmia mechanism, and one of the bradyarrhythmia is SA node dysfunction. So these parameters are very important in you determining SA node function. Okay? Dr. Augustine, is it clear?
Yes, sir.
Okay, great. So another method of determining the corrected sinus node function or SA node function is to do the ratio of the SA node recovery time over the basic cycle length times 100. So if that ratio is above 160%, you will note that there is a problem with the SA node. So what we are saying in essence is that the longer the SA node recovery time, the more the abnormality of the SA node function. Okay, apologies. I want to quickly charge my laptop. It's almost shutting down. I think we started together. Okay, apologies. I just have to quickly charge my laptop so that. Okay. So since we've understood that aspect for SA node, then we should now try to also understand the one for AV node. As we previously said, AH between the atrium and the EAS defines your AV node conduction property. HV defines below the AV node. So that means the EAS to the Purkinje's. That is what is defined by your HV. It's conduction time between the EAS bundle and the ventricle. Now, so that means if you have prolongation of the AH above 125 milliseconds, you will say that there is a nodal block. If you have prolongation at the HV interval beyond 55 milliseconds, you will say you have an infranodal block. Is that clear? I want to be sure it's clear.
Yes, sir.
Okay,
Prof,
good.
is clear, but Prof, sorry,
Yes, sir.
Yes,
sorry to take you back.
sure. Let's.
This 60,000 we used to divide a value to get this rate. How do we get that calculation before we divide the 60,000? I think I missed it at that
How do you
point.
get? How did we get
But then you
60,000?
said you calculate the rates, but I know I got 60,000. But you say you divide something by 60,000.
Oh, okay. For example, no. Okay, let me show you some what you are saying. Let me explain. You can also use your surface ECG, right? Let's say we do RR. So, if you want to get heart rate now, we use RR interval on surface ECG, right?
Yes, sir.
Good. We will just count the big boxes and divide by 300, as in 300 divided by big boxes. Right?
Yes, sir.
Remember? Do you know that you can also convert it to time? Remember that each small, tiny box, or each big box is 0.2 milliseconds, right?
Yes, sir.
0.2, that's 200 milliseconds. Big box is 200 milliseconds, like 0.2 seconds. So that
Yes, sir.
means your same RR interval, you can convert it to milliseconds, right?
Yes, sir.
Yeah, so it's something you can do yourself. So you just take your ECG, let's say you get RR interval of 4 boxes. How many milliseconds would that be?
800 milliseconds.
800, right?
0.8.
800.
0.8. So 0.8 seconds or 800 milliseconds. So divide
Yes.
60,000 by 800 milliseconds. What will you get? Am I still audible?
Yes, Prof.
Yeah, so 6,000 divided by 800. What did you get?
75.
75.
So you can now understand why 300 divided by 4 boxes. How many bits will you get?
75.
You now understand now.
Yes, sir. So if we're not calculating the rate using this EP, like for example, the high ROA, if I using the twin
Yeah.
interval now to calculate, how do we not go about it?
I didn't get your question exactly. Is that if we, I'm not getting.
Are using the high right atrial lead here,
Yes.
and it's catheter. How do I calculate the heart rate using the EP? EP
So
we're
you know
using.
that, okay, I get your question now. So how do you use the IHRA now to determine your heart rate, right?
Yes, sir.
So on the ECG or on the monitor, there's caliper, right? So the same way you can see this caliper, all these things are caliper that they are using on the machine. So all I need is to put one caliper here and put the next caliper here. I need to tell you the time interval. You get what I mean, sir? So the same way we do surface ECG, where we use RR interval, we can also use PP interval, right, to determine heart rate if they are regular. Yes or no, sir?
Yes, sir.
I don't know if I'm clear. Hello.
Yes, Prof, we can
Yeah.
hear you.
Yes, sir.
I don't know if I was able to answer his question. But is it clear? Dr. Bassi, Dr. Freedom, is it clear?
SIT, but I was thinking of a practical example where we'll be asked to calculate the heart rate using the EP from the EP and have
Yes.
the timing.
They will tell you the time interval. We'll still get somewhere to calculate. I'll show you. Okay, maybe I should just go there. So look at this one now. So let's look at, this is HRA, right? Can you see that? Am I audible?
Yes, you are, sir.
So look at the HRA. They have told you all the A's. So look at the HRA between this and this array. How many milliseconds is that? You can see it's 930. Yeah, the machine will show you now. If you put one caliper here and put another caliper here, it will show you 930 milliseconds. So divide that by 60,000, you will get your heart rate. Hope it's clear, sir.
Yes, sir. It's very clear now.
So, sir, it means the heart rate is like 60,000 divided by
60,000
the
divided by
basic
930.
circle length.
Exactly. Because heart rate is measured in minutes. No be so.
Yes, sir.
So we should now know how many milliseconds makes a minute. That's 60,000. True or false?
True.
Okay. Hope it's clear, sir.
Okay, very clear now.
Okay. Okay, so I want to introduce some terminologies when we are doing EP. So anytime you see the word S1, S2, I want you to, so that you not get confused what they mean. They are just spacing. So S1 means that you're adding a stimulus. That means you're already pacing. So you can, now, another important thing I want to state here is that you can pace the chambers of the heart from any of these catheters, any of them. Either the HRA, you can pace from the bundle, you can pace from the CS, you can pace from any of these catheter, they can pace. So they have two functions. They can record electrical activity and they can also initiate pacing. Okay? So you can pace from any of these catheters. Anytime you start pacing, the terminology changes. For example, we are not pacing here now. This will now be A, you have H, V. But when you start pacing, you will call that pacing electrode S. That's you are adding stimulus. So if you are pacing at a particular rate, let's say you are pacing at 150 beats per minute, you will call it S1. So S1 is pacing at 150 beats per minute. So just like what you see here now. So this S1 can be pacing at 150 beats per minute. Okay? So that means any electrical activity you see related to it will now be A1, H1, V1. Hope we get that. You will label it yourself. A1, H1, V1. You're the one that will label it yourself. Okay? Now, another thing you can now do is that you can now add another premature beat shorter than the beat at which you are pacing it. Premature beat means that the duration is shorter. The impulse came at a premature timing. That means shorter duration. So that can be at maybe 160 beats per minute. Remember, we're going at a pacing rate of 150 beats per minute. Then later we increase to 160 beats per minute. So that time, that bit that changed the duration will now be called S2. So if you only stopped at S2, you call it a single extra stimulus or single premature beat added. Okay? So that means if you have added an S2, you will call the electrical impulses you get A2, H2, V2. So let's go to an example here. We started, remember, this is baseline. There's no pacing here. Baseline. Apologies, they started pacing here, S1. So they started pacing here. So they will call everything that is related that they record here as A1, H1. And anytime they now shift to a shorter duration of pacing, then you call it A2, H2. If there is a V, V2. Okay, we're just trying to say that use that terminology when you are pacing. The S1 means that you started pacing at a particular rate. If the duration is now shorter, you call it S2. If the duration is now even more shorter than S2, you call it S3. And like that. Okay? So at this time, they didn't pace, yeah, but here they started pacing at S1. So when you see, so anytime you are pacing, the electrode you are using to pace, the morphology will change. Okay, I will still come back to this, but I just want to make you understand that anytime you are pacing, the terminology of your AHV will change. So if you are pacing at a particular rate S1, you have A1, H1, V1. If the pacing becomes shorter, it goes to A2, V2, H2. If it's now far more shorter, it will come S3, A3, V3, and things like that. So just to show that your pacing rate is changing. Okay? So we will further buttress this, but I needed to bring in this term so that we understand the pacing rate that can be changed. Because part of the things we do in EP is to induce arrhythmias, right? Or check the conducting property of a tissue. And you can only check the conducting property of a tissue by trying to stress that tissue by pacing it faster than expected. Okay? So if we are pacing with a single extra impulse to it, you will say that's a single extra, that's an S2. If you add a far shorter, more than S2 to the pacing rate, you call it S3. The baseline pacing rate is S1. If it's shorter, if you add one shorter one to it, you will call it S2. If you add another shorter one to the S2, you call it S3, and S4, and like that, and like that. So that's what we call single extra, double extra, triple extra. Okay. Incremental simply tells you that you are pacing at a particular base rate. You are not adding any single extra or double extra to it. Okay. So I'm further buttressing what we just discussed, that you can pace from anywhere, either from the ventricle, from the atrium, from the east. Okay? Your pacing rate can change. So for example, now, this is a baseline pacing rate at 400 milliseconds. Let's say 200 beats per minute. B is showing us a pacing rate at 600 milliseconds, but they added a single extra 250 milliseconds. So we know that the duration, the beat will be faster than the pacing rate of at 600 milliseconds. So for example, if you are pacing at 600 milliseconds, that means you are pacing 600 divided by 60,000 would be like, you are pacing like, would that be 100 beats per minute, right? Someone has a calculator there, right?
Yes, 100.
100 beats per minute. Now, you now reduced the duration to 250 milliseconds. So that's what rate would that be now? So 60,000 divided by 250 will be what?
240.
So you can see
240.
240 beats per minute. So you can see
Yes, sir.
that it's faster. So another one can now come at 100 milliseconds, things like that. It just, what your intention is to induce, either you want to induce an arrhythmia, or you want to see the conducting property of a tissue, like AV node now. You are placing AV node at 200 beats per minute, then you increase it to 250 beats per minute. There will be a time that it won't allow conduction into the ventricle, right? There will be AV block. So you are trying to check the conductive property of that tissue. So these are the things we use to determine conductive property of a tissue or induce an arrhythmia. Okay? So I hope this is clear. I'm sure this. Do you have any questions? This should be. If you have any question, let us know. Okay, so if it's clear, we can move forward. Now, so let's go to basic EGM that you see. So we said that when you're seeing an EGM, you would see surface ECG. So you can determine the type of surface ECG you want and the number of surface ECG you want. So this is like a standard 3-lead surface ECG. One other important thing you should know about when we are doing EP is that the cycle speed will be increased to 100 beats. So 100 milliseconds. Remember the normal ECG speed, swift speed is usually 25 milliseconds, right? 25 millimeters per second.
Yes, sir.
Yes. So, but when we are doing EP, that swift speed will be increased to 100 millimeter per second. Why? So that you can see things clearly. Imagine you are pacing something at 200 beats per minute. Most of, if you are using 25 millimeter per second, everything will be crowded. You will not be able to see the abnormality or slight changes. So to see that slight changes, you have to slow the rhythm strip. So that is why everything looks so wide. You would think the patient has bradycardia. No, it's not bradycardia. It's because the swift speed has been slowed down by increasing the speed to 100 millimeter per second. Okay? All right. So as we said, the EGM will be represented on your monitor. The catheters are represented here. So we can see the catheter. This is the RV catheter, HRA catheters, the East catheter, East bundle catheter, okay? Which is for this one now divided into the proximal and distal East. You can see the CS catheter, 10 poles, and they represented all the 10 poles here. Okay? You can decide to just make it proximal, mid, and distal. You can decide to make it a single reading. So you are the one that will decide the number of poles you want. So you will notice that your RV EGM is only showing one spike. Okay? That means that we said that the RV catheter is deep into the RV, so it can only monitor right ventricular activity, RV activity. It will not monitor East activity, it will not monitor atrial activity. So all you see is just ventricular activity. And you see that it's corresponding to your surface QRS depolarization, right? To tell you that that's ventricular activity. So if you look at the HRA, it's high into the right atrium, and the only thing you're going to monitor there would be the what? Atrial activity. And you will notice that it's also going to correspond with your surface P wave, right? Okay. Now, we've also told us that the East activity is sliding between atrium and ventricle. So that simply means you have the A wave, the East spike, which represent the bundle of East, and the ventricular activity. We said the AH represents the AV node, the HV represents the East to the Purkinje's, right? So you can see this. So East catheter is very, very important in monitoring AV nodal activities. we have, as we said, we can have the distal and the proximal east. So it will represent similar things because they are close to each other, right? We have the CS catheter. Remember we said the CS catheter is decapolar. The most distal is the one to, you label it from the distal end to the proximal end. So that means the most distal is closer to the lateral wall of the left atrium. The most proximal will be closest to the right atrium, where the CS orifice is in the right atrium. Hope we get that. This is very important so that when depilation starts, you expect that depilation will start from the SA node that is close to the I right atrium, right? It will get to the AV junction, right? And so that means the East catheter will be the next person to pick atrial activity. Okay, the East catheter will be the next to pick it before the ostium of the CS picks it, and the last person to pick atrial activity will be the person close to the lateral wall of the left atrium. So that is what you expect as a normal conduction. If there's an aberration in this conduction, then you can detect the source of the arrhythmia. So what do we mean? You would expect that I right atrium should peak atrial activity before the CS1 and 2. Okay? You expect CS9 and 10 or the East catheter to peak atrial activity before CS1 and 2. But this is what you call the concentric conduction. But in a situation where CS1 and 2 is coming earlier than CS9 and 10, then it tells you that an accessory pathway is activating itself faster in the left atrium than the right atrium. Do we get that?
Yes, sir.
Yes, sir.
So that means if CS1 and 2 is coming faster, is getting early atrial activity than CS9 and 10 or than the East bundle, then it tells you that there is an accessory pathway that is conducting atrial activity faster than the right atrial conduction. So it tells you that, oh, most likely there's an accessory pathway there. So that is how we detect accessory pathway and the location of accessory pathway. The same way, if CS5 and 6 is faster than CS9 and 10 or faster than is a spike, then it tells you that the accessory pathway is around the mitral valve or septal activity compared to the conduction coming from the normal AV junction. So you can say, oh, there's an accessory pathway there, there's a faster conduction or early activation there than the other sides. Okay? We will see further when we start looking at the Brunwald MCQs. We'll see how to make those diagnoses. But this is the baseline that will help you tease out where the diagnosis of the problem is. Number 2 is that when you have prolongation in this AV duration, you will know there is a AV node problem. If you have prolongation in the HV in pathway, you will know that it is a what? Infranodal problem. So these are just the basic EGM that we should have in mind. If you can study this EGM very well, teasing out every other EGM will just be a piecemeal. Do we have any question on this EGM? Okay, so we can move forward. So just to further buttress what we were saying before, conduction starts from the I right atrium and ends in the RV apex, right? Or the left ventricle.
Remember we said that the East catheter can sense both the atrium and ventricle because it lies in the atrioventricular groove. So it means that this other last spike in this CS1 and 2 now is talking about the lateral wall of the left ventricle. The RV will only sense activity in the right ventricle. It will not sense activity in the left ventricle. But the CS catheter can sense activity in the left ventricle. Okay? East catheter would tell us the junction between the atrium and the right ventricle. Okay? The CS9 and 10 should depolarize earlier compared to CS1 and 2. Okay? We can measure all our cycle length, our intra-atrial conduction time, that means between SA node conduction to the lower end of the right atrium. We can monitor our AH conduction time, our HV conductor time, and things like that. Okay? So this diagram just helps us to buttress our AH, the East activity, and the HV. There are conditions where this East can split. We'll see that in our Brownward questions when we are looking at it. It just tells you that there's a problem with the East. So if you're having two East spikes, then it tells you that there's a conduction problem in the East bundle, so which is the infranodal problem. Okay. We've discussed sinus node recovery time, meaning that after suppressing the SA node and the SA node recovers, the time interval between the last suppression by pacing to the time it recovered is the sinus node recovery time. So for example, now we said S1 means you started pacing, right? So we started pacing here and pacing here and pacing here. You have suppressed the SA node. Now, by the time you stopped pacing, so the SA node now recovers. So from the last pacing atrial activity to the recovery of the native SA node function is called the sinus node recovery time. Then we can correct for the sinus node recovery time by subtracting the baseline cycle length without pacing from the sinus node recovery time. That will give us the corrected sinus node recovery time. That is part of the Brownward MCQ question. Hope it's clear. So we've discussed this earlier, that we can add single extras, double extras, triple extras by shortening the coupling interval of this pacing rate. That's what is explained here. Okay, so for example, you have the pacing at S1, you have your AHV, so that will be A1, H1, V1, is spaced again. You are pacing from the atrium here. So the shape of the activity will change. It will give you a box-like shape from the catheter you are pacing from. If you are pacing from the ventricle will give you a box-like shape. If you are pacing from the CS will give you a box-like shape. So this pacing spike, box-like shape, tells you that you are pacing from the HRA catheter. So if you are pacing there, you have your A1, H1, V1, because the East catheter would sense the pacing at the lower end of the right atrium. It gives you the East conduction, the V conduction. If you shorten the time interval of your pacing to S2, it's shorter in duration. So what you now have will be A2, H2, V2. When you stop pacing, what you have is A, H, and V. Hope is clear.
Mm-hmm.
Yes, sir.
Okay, good. So when we are doing that pacing, we can now check the conducting property of the AV node. Okay. So we give you an example here. We can see our pacing. They started pacing at 500 milliseconds here. And the top upper corner, the S1 is at 500 milliseconds. The S2 is at 300 milliseconds. We all know that the shorter the milliseconds, the faster the heart rate, if we use our 60,000. So they started pacing at 500 milliseconds here, and you can see they measure their AH interval and HV interval. But when they shortened the duration to 300 milliseconds, you can see AH and HV. So let me ask one of us to tell us, Doctor, we'll be ending here. Dr. Bassi. Dr. Bassi, are you with us, sir? Sorry, EP
Yes,
keep
Prof.
sometimes. Okay, thank you for not sleep. So tell us, what did you notice in this? What abnormality can you tease out from here? So I'll focus on it for you, the AHV. Between the first pacing at 500 milliseconds and they shortened it to 300 milliseconds. What did you notice? I'm trying to circle around it.
For what I noticed is that, for this AH, you said the rhythm is supposed to occur with the P wave of the surface ECG. I think,
So remember, when they pace, it will pass through the AV node, right? To the ventricle.
Yes.
So when they pace here, look at this side. You can see my arrow, right?
Yes.
And you can see
S1.
this side, Abby.
Yes.
When they made the pacing faster, what did you notice? Yeah, someone is already telling us.
AV nodal delays.
Yeah, so Dr. Bassi, did you notice something here?
No, Prof. I don't think why it's saving that delay.
But do you see where my circle is?
Yes, where you have A2S.
Do you now understand?
S2.
Yes. Is this telling you something?
Yes.
What is it telling you? So, Dr. Bassi, let's ask you again. What's the purpose of AH?
It's to check the AV node conduction.
Okay, so look at this A1, H1, A2, H2. What do you notice?
There's a delay. The distance
Fantastic.
between A1 to AH and the distance between A2 to AH. A2 to AH is longer. See the delay.
Yes, so what does that tell you?
There's AV node delay.
You can now understand why he said AV nodal delay, right?
Yes, sir. Yes, sir.
So you can see it's not hard at all. It's actually just know the
Thank you, Prof.
basics, and it will be easy to just tease it out.
Thank you, Prof.
Okay.
Pardon, what do you assume? I say I haven't loved it. Oh, that or only a tree. So open it. Okay.
Is that asking a question? Apologies, I don't hear plenty language like that. I don't know if he's asking questions or something. Okay. I guess we can move on, right? So it's just to emphasize what we are saying here. So let's look at this one too. So remember we said when they start pacing, it will look like a box, right? So you see that box? So they've now helped us to label it S1, right? So Dr. Basti, I'm sure you'll be willing to take this one. So what did you notice? They have helped us a lot.
Okay. Prof, this one is it for the his bundle now or still?
You see, you will have to use your catheters very well to see what the problem is. So let me go to the previous slide. So to further buttress this previous slide, okay? Maybe you now use it to tease out the next activity. So in this previous slide, they paste S1 here, right? The East bundle, the East catheter below recognized Abi, you are pasting from the I right atrium. So the East catheter recognized the A, the E spike, and the V, right?
Yes.
So they kept pasting again. So they now help us to label it well. A1, H1, and the V. So the V will correspond with your surface QRS.
Correct.
And you get what I mean? So they increased the rate
Yes,
here. S2, we saw the A2, right? We saw the small east, but the distance was prolonged, right? And we still saw the V2, right? And the V2 corresponds to your surface QRS, right? Is it clear?
Yes, sir.
So now they didn't paste anymore. So there's sinus node recovery here. Okay. There's the east spike, right? There's the V. Are you getting it, sir?
Yes, sir.
So the same way, A, H, V. No more pacing. There's something I still want to bring to our attention here later, but I want us to get the first basic thing. Now, let's go to this one. They paste, Abi. You go and monitor the activity conduction at the catheters below. Abi, since they paste from the I right atrium, you go and monitor activity, how the pulse went from the catheters below. So the closest catheter will be the east catheter, right? So
Yes,
you
sir.
can see the A here, you see the H, you see the V, right? V will correspond to your surface QRS.
QRS.
So paste again, A, the label for us, H, correspond to your surface QRS, right? They paste again at S1. So that means they are still maintaining the same pacing rate. A1, right? H1 and QRS, Abi, V.
Yes, sir.
But they shortened now at 280 milliseconds now. And if you monitor your east catheter, right, you can see it's Abi. So
Yes.
tell us what has now happened. Or let's put it this way, what are the other things you expect that you are not seeing?
Okay, I'm not seeing the what is here now. This is like the V.
Is
Where
it
the arrow
corresponding to
is
is it
V.
corresponding to your surface ECG?
No.
So why you look at the V? If it's a V, it should correspond to your what?
Surface is.
So what has it? So what has this told you us?
There's a bundle. It's as if there's a bundle block. There's a bundle here.
No, don't use the word bundle branch block on EGM. It's not. It's only on
Sorry,
services
sir.
you talk about M pattern. Leave that one.
I don't know how to
So
put it
you are
down.
monitoring fragments. So
And there's a delay in the conduction.
So Dr. Bassett, there are some things you expect that you are not seeing. What are the things you are expecting? They just paste
I'm
from the
supposed to see
So you're supposed to see what?
supposed to see A. I'm supposed to
Mm-hmm.
see his spike, and then I'll see the V.
Exactly. So the question, are you seeing them?
No.
And when they stopped pacing, you now did what? Saw A, Abi? You saw
Yes.
H,
His spike
you saw
and
V,
V.
which corresponds to your surface ECG. So what has this told us?
Sinus arrest.
Don't worry, it's not hard, it's straightforward. I know you are getting it, but it's inside you, but you just want to bring it out.
So that's an A, right?
Yes, this is an A, right? They
Like,
labeled it.
meaning that is as an arrest or something, sinus arrest or something.
Ah. Will you have a sinus arrest if you have an atrial activity?
Atrial activity. Okay, an A.
What are you
So then
expecting
they
next?
delay conduction. After the
There's what?
H and
person H
You expect the
and
H
then
and
Uh-huh.
the
V.
spikes.
So what does that
So
tell
there is
you?
no, so there's a delay in the conduction from the east catheter. That there's a delay in conduction from there till it gets to the
Okay.
left to the ventricle.
Exactly.
So there's a
So
delay in
that
that
means that,
conduction.
is it so I'll give you one of these options to choose. Is it a delay in conduction or no conduction? Dr.
No
Obasi?
conduction.
No
No
conduction,
conduction.
because you cannot even see surface QRS at all. So no conduction. You get?
Yes, sir.
So that is why it's called a nodal block. Do you get it now? There's no
Yes, sir.
H, there's no V. Do you get it, sir?
Yes, Prof. It's very clear now. Sorry for
It's
stressing
very
you
clear,
to
Abi.
go through all this.
No, I'm just happy that we are getting it, because this is the best way to get, or else we can start talking and talking and talking, explaining. But his ability to tease it out, you find that it's not hard at all. You get it?
Yes, sir.
So I will use this to tease out something for us. So let me let Dr. Bassi rest.
Thank you,
Dr.
Prof. Thank you, sir.
Dr. Augustine.
Yes, sir.
Good. Thank you for staying awake. Great. So I want you to remember, we've looked at this slide before. We noted that at the S1 there was A1, H1, V1, right? At the S2
Yes, sir.
there's a prolonged AH, right?
Yes, sir.
And there is a normal HV, right?
Yes,
If you
sir.
compare this H2 V2 to H1 V1, they look like the same duration.
Yes, sir.
Like H2 H2, right? Good. So I want you to now look when the sinus reading returned. They didn't pace for me, they stopped at the S2, right?
Yes, sir.
The sinus reading returned. I want you to have a look at all this, where my arrow is, and tell me, is there something unusual?
Okay. Then,
Just look at where
A,
my arrow is.
there is
Mm-hmm.
H, and there is V also,
Mm-hmm.
where your cursor is now, which corresponds to the surface of ECG. Okay. Okay. Is one proximal. Okay. It seems to follow a sequence. The A, the H, and the V.
Okay. Is that all to it?
Okay.
My arrow is giving you a clue.
Okay. The I think the word you used the other time, you said concentric pattern or something like that.
Okay.
The sensing of the A should like, I want to use the word to describe it, should follow each other, but it seems to be on the same spot and going down, almost moving leftward rather rightward. I don't know if I'm
Okay.
making sense.
Yes. Yes, you are getting it. So
Okay,
let's
okay,
help you
so,
put it in proper perspective.
Sorry, sir. Can I
You,
try?
you
Is
are
it like,
getting
is it that
so
okay.
C9 to 10 came before his proximal?
Exactly.
yeah, exactly,
So
yeah.
let's just explain what it means actually. So that's what he was trying to put out, and but I'm happy you're getting it very, very well. So let's get it from here. I want you to see the normal EGM, right? Remember the catheter is in the right atrium, right?
Yes, sir.
And the CS catheter ends at the lateral wall of the left atrium, right? So our first question should be,
Yes, sir.
who should recognize atrial activity first? Right atrium or the lateral wall of the left atrium?
Right atrium.
Right atrium.
Right atrium. Right atrium should come even before is A, Abi,
Yes, sir.
and it should come even before 9 and 10, because 9 and 10 are still in the lower part of the right atrium, right?
Yes, sir.
Good. So that brings us back to this. So what have you now noticed here? Can that explain this?
Like a should I say accessory
Yes.
pathway.
Located at which area?
Okay. I think the right, no, the left. I think the left, around the left ventricle.
Why are you saying 11?
Okay, because C9 and 10.
Mm-hmm.
C9 10
Mm-hmm.
is a bit leftward compared to
Just use the word earlier or late.
oh, where is it in my head, sir? I think earlier.
So it's earlier. So 9-10 is earlier than
HRA and
HRA.
yes, sir.
And so fantastic. So if it's earlier than HRA, where does C9-10 represent?
C9 10 should be around the should I say free wall of the left ventricle, sir?
No. So I think you didn't get how we number the catheter. The most distal end of the catheter.
Okay.
So this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. I think around the
Right atrium.
right atrium now. Right atrium.
Lower right atrium, right?
Yes, sir.
You get, because if you are sensing atrial activity fast earlier here than HRA that is close to the SA node, then it tells you that the activity is starting around here. Do you get that?
Yes, sir.
So you can now see how we make a diagnosis of AVRT. So the same way, if this one is earlier than HRA, it will tell you that the problem, this accessory pathway that's activating the heart is from around here.
Yes, sir.
Do you get it now?
Yes, sir. So the most distal is 1, 2, starting
Yes.
from
So
1,
it
2
starts
from
from the tip of the catheter.
okay.
So the tip of the catheter is 1, 2.
Sir.
Hmm?
Okay, sir.
It's clear now, right?
Yeah, very clear. Thank you, sir.
Okay. Do we have any question regarding this please. Do we have any question regarding this? So you expect that the normal should be HRA before the ease, before 910, and it should go concentric that way. But this is eccentric because
Sorry,
910
but
is coming before. Yes.
okay.
I have a question.
Where the issue is now, yes, sir. Where the issue is this HROA. Is that where the problem? What I mean is where you have the HROA does not have conduction because this one that is HBED and HBEP, they have the conduction.
So what we are saying to tell you that look at this lining of everybody. Which one is coming first in all this catheter? From here, then which one is coming first in activation? Can you see it clearly, sir?
Yes, Prof, I can see it.
So which of the catheters is coming first in activation? Tell us now. Which one is
It
coming
looks like
earliest? Uh-huh.
C9, C10.
Exactly, C9, C10. And we told you the location of C9, C10 on this place. Look at where C9, 10 is.
Yes.
I'll use this. Look at where C9, 10 is. It's getting activated before the guy close to the SA node. Do you get that, sir?
Yes, sir.
So if C9, C10 is coming before HRA, it tells you that accessory pathway is around C9, C10. Hope is clear, sir.
Yes, sir.
Hello?
Yes, sir. But
Okay.
if you go back
So
to
just to tell you that,
the
that's how we make
EP
diagnosis
himself,
of an accessory.
when you go back to the EP himself, the one you're using to show, no, not this one, the particular one. The one in okay, it's still confusing why this is coming first because the one up is almost at the same line with it. The one next is
So the one up is almost at the same line, right?
yes,
Uh,
that guy
but
up.
it's far earlier than HRA.
Yes,
Should you be far earlier than HRA?
no, sir.
So
HR should come first.
yeah, and don't forget your CS orifice and its bundle. Are they not close to each other?
They are.
Yeah, so you can now see why they're almost close to each other compared to your HRA. So who should come first?
HR should come first.
So you can now see that there's a problem with activation around here.
Yes, sir. That's clear.
So it's clear, right?
Yes, sir.
So this is how you make diagnosis of AVRT. Meaning that he has an accessory pathway that is running faster than the SA node. Okay? Hope it's clear, sir.
Yes, sir.
Yes, sir.
Okay, great. I think we need to rest tonight so that I've sent the slides to Dr. Gordon. I'm sure he's able to post it on the platform. And then we should continue from here and now do MCQs of Brownwood if they give us another allotted time. Okay. So thank you very much, everyone.
Thanks so much, sir.
Thank you, sir.
Thank you very much, Prof, for breaking this down. I mean, most of us, it's been a problem, but with the way you've been able to break it down, I'm sure for now it's very easy for us to understand. We are very grateful to you. So, Prof, we'll stay in touch and then arrange for another session where we can solve the questions in the wrong world. I remember we're struggling to solve those questions when we got there. So it will be an opportunity for us to get it solved. Thank you very much.
Sure. Yeah. Oh, you're highly welcome.
Prof, I'm very grateful, though. Very naive to EP, but it's an eye opener.
God
I'm very
bless you, sir.
grateful.
Okay, so let me see the. So I've put the slides on the page.
Prof.
Please, you can go ahead. Sorry, Dr. Godia, you can go ahead.
Yeah, so sorry, just wanted to send my regards, Prof. Yeah, stop.
Okay, so the slides are on the page, the WhatsApp page, so we can have access to it as well. Okay, please, any more questions or contributions?
And it's just that since we have done this, also create time for pacemaker programming and all that. Those gray areas.
Yes, sure. We'll do that. Okay, Dr. Asian, please, any comments or any information for us? Okay, not really. Okay, so okay.
Sorry, Dr. Gordon.
Yes, please, Dr.
Hello?
Augustine.
Okay. So I think since the symposium has ended, so for weekends, are we going back to, is it 6-9 now instead of 7, or we're still sticking to 7-9 or something that we can agree?
Okay, yes, we can agree. So please, what do you suggest? Do we maintain the same time for the weekend, the 7 p.m., or we go back to the old 6 p.m.?
I do 7 p.m. We try to 7 p.m.
7 p.m. is fine by me too. But we should talk so that we cannot like for which one is more complete.
So so far we have 7 p.m. suggestion. Dr. Augustine, which of them do you
Yes.
choose? 7?
I'm fine with 7.
Okay.
7 to 10.
Okay. Dr. Basi also made a comment. Dr. Basi, which one?
7.
Okay. Please, any other comments on that? Or you can type in the chat box.
Okay. Then also I've reached out to the people taking their guideline presentations for Saturday and Sunday. So we're good to go. And also pull up their name. We're good to go for tomorrow and Sunday.
Okay. Thank you very much, Dr. Augustine. So yeah, that would be That'll be very good because we have little time. So we don't need to skip these presentations. So we thank you that you've been able to get that organization done for us as well. Okay, if there are no more comments, so we had just one more question left for that section. I don't know whether we should finish that one question or close and come tomorrow and continue.
Let us do it now, brother. Let us do one question.
Okay. Okay, so Dr. Philothea, question number 55. That's our last question.
Okay, thank you.
Okay, you can go ahead, please.
All right, let me. Okay, question number 55. A 58-year-old man known for hypertension and smoking suffered chest pain and dyspnea previous 48 hours. And the previous 48 hours, he consulted the emergency department for persisting symptoms. The rest of lead ECG admission is shown in Fig 4.9. What is the diagnosis? A. Takotsubo cardiomyopathy. B. Pericarditis. C. Anterior subacute MI. D. Cardiomyopathy, hypertrophic, obstructive. E. Hypertensive heart disease. Okay, so the ECG is shown in Fig 4.9. Okay. Okay, so this ECG belongs to this 59-year-old man. Okay, significant findings. We can see there is ST segment elevation, ailates, V1, V2, V3, V4, V5 with T-wave inversion. Okay. With T-wave inversion still in those leads. Okay, this is an MI now. This is an MI. I don't know if there are still other findings that I can locate in the ECG. If anyone can look at. However,
Gordon, can you please go up to the question, please?
okay, the answer should be C now. This is anterolateral MI. So what makes it subacute? Is it because of the T-wave inversion? Hypertensive is not hypertensive heart disease.
Yeah, so the acute one would have ST segment elevation. Just that. But as time
Yes,
progresses, a Q
yeah,
wave
the one.
developing.
Okay.
And after the Q waves, then we start developing T wave inversions also.
Okay.
And then whilst that is going, the ST segment two also starts coming down. So
Coming
if
down. Oh,
where you have the K waves, normal ST segments, and T wave inversions.
inversion. Okay.
Finally, the T wave may come back to normal, then the K waves persist.
Persist. Okay. That shows ischemia. All right. Thank you. So that is subacute MI.
But let's check the answer because a diffuse T wave like this can still give you Okun can give diffuse T wave, apical Okun
Okay.
trivially.
Yeah.
Okay.
So this also looks like Wellens with the biphasic T waves and all. But with the
Yes.
what won't speak for the Hukum is the fact that the R waves, the QRS are not really that tall. Like, but that one comes as left ventricular hypertrophy, so you tend to get very tall, like QRS complexes as well.
Okay. For hypertrophic cardiomyopathy.
Yeah.
But how do you know on the ECG that something is subacute? Is it because of Q waves?
Yeah, because of the fact that the Q waves are there, meaning that at least it's not like very fresh, and also the T waves, there are T wave inversions. So in the early stages, it's just the ST segment elevation. The T waves will still be upright in the early stages, and then later,
Where the
sorry,
Q wave? I'm not where the Q wave?
Q waves, the first negative deflection
Mm,
without any R wave.
of course, I know. So those are Q waves.
So at least this is a Q wave. There's a Q wave.
Okay. No, I cannot even see the P there. I know the definitive expression after the P wave is the Q wave. And I can't see the P that's making you say that it's Q.
The P.
You can see P wave in lead two.
But I know. I mean the V1,
Okay, in
the
those ones that
V,
are
the V2,
highlighted.
V3. And because if you see the P wave, the net negative deflection of the P wave is the Q wave. If you go to the limb leads, can you see any Q wave there?
Sorry, in which one?
In the limb leads, lead 1 to 2, 3, AVL, AVF. Where are the Q waves? Anyone?
Um, so in lead two, I don't see any Q wave. In lead AVL, there's a small Q wave, but as to whether that is significant, it's not more than 25% of the entire QRS amplitude, and it's not more than 40 milliseconds deep. So that may not qualify for a significant Q wave. That is in AVL in one, but there appears to be small negative deflections. That's our Q wave, but not pathological Q wave. And yes, and AVF2, there are no Q waves there. So I think the main problem is what we are seeing here from V1 up to V6, where there are T wave inversions.
The areas that are affected.
Yeah, and V1, V2, V3, V4, the T waves are actually biphasic. So biphasic T waves may also speak for Welland type 1. And especially if the first part of the biphasic T wave is positive, as opposed to that of hypokalemia, where you get although you may have biphasic T waves, the first part.
What is it biphasic? What is it biphasic?
So the first part that is starting from here is actually up. So if there's your isoelectric line, the first part is up together with the ST segment elevation. Then the second part comes down.
The positive and negative deflection, positive deflection and negative deflection of the T wave.
Okay, thank you.
Welcome. So please, any more contributions on that?
Just was trying to say something. I don't know if he's still there, but I'm sorry.
Okay. Okay, so this is our last question for this session.
What's the answer now?
So the answer is the subacute one. The anterior subacute myocardial infarction.
Oh, wow.
So for the Takuchu, I don't know whether there's specific ECG findings for them, but from what we've saw, just non-specific T wave changes that may happen, or ST segment elevations, but not really specific for Takuchu like any other MI. For pericarditis, there is not suggestive. For hypertensive heart disease, the voltages are not that high for us to be thinking about hypertensive heart disease, and the same for the myopathy as well. The cardiomyopathies may also have Q waves, all right, but those Q waves tend to be very narrow Q waves, especially for the apical cardiomyopathy. That's apical hypertrophic cardiomyopathy. They tend to have very narrow Q waves, like they have the Q waves, but they're narrow and sharp as well. So maybe in the context of Q waves, it may be a differential, but at least the voltages, we are not seeing very dominant QRS complexes here. So I think the answer should be the anterior subacute myocardial infarction. The subacute because now the T waves are inverted. The Q waves also, meaning that at least it's not very acute. But the ST segment is still elevated. And it will take time for the ST segment to come down. And then later on, the T waves may or may not return to normal place, but the Q waves will persist. Okay. So if there are no more contributions, then we'll have to pause here, and then tomorrow we'll start the next aspect. And also, I'm sure from Monday we should start.
There's 56 to 60, hope you know.
That one was done yesterday.
Okay. Maybe I don't know. Okay. Thank you.
Okay. Okay, if there are no more contributions, then we'll pause here. Have a good night. But Dr. Gestin and Dr. Mohammed, please kindly stay behind.